All right, everyone, this is our last physio class. You guys, don't worry, get me for a whole another year. We get to have, this is where the actual fun part starts, because we get to go into farm proper. Everyone loves that class. And then we do epi-bio. Everyone especially loves that class. It's very interesting, and people are really digging the material and get a lot out of it. So it's okay. It'll be fun. We'll make it fun, I hope. A lot of people think epi-bio, they're just like, ugh, even more so than farm, but we'll make it fun. Okay, anyone else want to log in? The teams. Is there any questions on anything before we get started? Nope. All right, so we'll see how these questions go. I'm gonna go and get started. Hopefully the other two can like that, or we have some team play going on, which is, oh, there we go. All right, fantastic. Saw a few Attack on Titan names. Pretty good. Okay, which area of the cortex is involved in the most simple of motor function or motor patterns? I like those quick answers. You guys are going to be good on the test tomorrow. What is? What's this question? All right. So remember that primary motor cortex is involved in really just like the very simple movement. So if you imagine like if you stuck an electrode down into that primary motor cortex, you'd see like individual muscles moving. It wouldn't be very complicated patterns though. But when you start to get like in the more supplementary motor cortex, the premotor cortex, that's where you get more kind of involved movements where you have things like positional movements of the body or the head in order to enact movement. So really the most simple things come with that primary motor cortex, right? What about the basal ganglia? What's that responsible for? In regards to movements, at least. Yeah, really complex stuff, right? So this is talking about like sequencing of movements. This is talking about doing things like getting up and walking over to. That's where we see like the things like the putamen and the caudate circuit get involved there, and that's where like you have things like destruction of dopaminergic neurons. You have problems where you can't really initiate movements very well because of a lot of the controls of that basal ganglia. So just keep that in mind. Keep kind of an idea of like where the movements are really kind of coming from. Most of the outputs are coming from that primary motor cortex through the spinal cord, but a lot of that gets filtered up through other areas that are a little bit more complicated and kind of distilling what that kind of motor pattern is going to be based on kind of what you decide that you want to do. Okay, moving on. A non-specific beta blocker would cause which of the following? So it's to affect beta 1 and beta 2 receptors. Close that door. Yes, ma'am. I don't know how to make it any bigger because it used to shrink the screen down to like a 4:3 kind of aspect ratio. You want to move up closer? You can sit on the floor if you like. Sorry. Bring like some like opera binocular kind of thing. Oh wow, that's a pretty even split between the incorrect answers. Okay, so let's evaluate this. Let's figure out why a non-specific beta blocker would cause these type of effects. So look at tachycardia. Why would a beta blocker not cause tachycardia? Right. Yeah. Yeah. So normally epinephrine, norepinephrine, when it hits beta 1 receptors on the heart, what does it do? Speeds it up, increases contractility. So if I put a beta blocker on that, that would cause that to be diminished, right? You'd have a diminished effect there. So if anything, you see bradycardia happen from that. Okay. How about the hypertension? Yeah, so normally this one's a little bit trickier because normally you think like beta 2 effects on the vascular smooth muscle should do what when you activate it? Should dilate, right? So what you end up seeing is that when you give a beta blocker, especially like a non-specific one, what you may end up seeing is that in general those drugs will end up kind of lowering blood pressure due to the cardiac effects. But what you see is that if you have the diminished beta 2 effects there, right? So you don't get that vasodilation. What else is affecting the vascular smooth muscle? The alpha effects, right? And alpha is going to be what? Right, it's going to cause vasoconstriction. So really, if anything, you would see a little bit more of the alpha effects on there, which would, if anything, kind of raise the blood pressure. You don't really see that technically, though, because most of the effects come about from the cardiac output, right? So you don't necessarily see hypertension from that. How about diarrhea? Yeah, that's going to be more kind of relegated to kind of muscarinic effects. If anything, you really wouldn't see any kind of effects on the GI tract. We'll certainly see with some other types of drugs how that can be affected, but certainly not beta blockers. And how about bronchoconstriction? Why would that be a problem? All right, because which beta receptors are responsible for bronchodilation? Beta 2, right? So this is actually a problem we run into with certain asthmatics, that if you were to have a non-specific beta blocker, you give it to a patient who has asthma, and they have an asthma attack, and all of a sudden they use their beta 2 agonist, all of a sudden those receptors are blocked up, and you may not be able to get any relief of that. So that's why one of those things we'll run into when we're talking about hypertension meds or just beta blockers in general is you got to be careful with asthmatic patients, right? In which case we might choose more selective agents, which will only affect things like beta 1 receptors. Okay, so this will come up again when we get into the actual pharmacology of things.
Can you repeat what you said about the alpha taking over when the beta doesn't do that?
Yeah, so with the hypertension effects, like you really wouldn't see hypertension from giving a beta blocker. Certainly you lose a little bit of that vasodilatory effects, which would just leave kind of the alpha effects. But primarily what you see is more effects coming from the cardiac center, right? So you're going to be seeing decreased cardiac output due to decreased contractility and heart rate. And so that would have a bigger effect on blood pressure than just what the alpha effects on the vasculature would be. Yeah. All right. Which neurotransmitter entities, just going to be neurotransmitter from here on out because it's saved characters, and midbrain area would assist in promoting sleep? All right, very good. Yeah, so this one's a little bit trickier just because of the dopamine, because they say normally like dopamine is going to be more inhibitory than anything, but you don't really see a lot of effects on sleep necessarily. It's more kind of involved like movements and things like that, or control of movements. How about acetylcholine though? Is that normally stimulatory or more? It's usually more excitatory, right? So especially those kind of really short bursts of excitation you can see from the acetylcholine. So that would not be the case. But the norepinephrine obviously is going to be very stimulatory. But yeah, serotonin and the raphe nuclei are going to be most important here for promoting things like sleep, right? So think about having a lot of tryptophan coming in from like turkey after Thanksgiving dinner. Think about that getting converted over serotonin and you get real sleepy, right? There's probably some other things going on there, but certainly that's one of the things they think. Yes, that is, yeah, so that's more specifically talking about what type of neurons they are, just like more the histology of the cells, but that's another name for that reticular formation. Yeah. All right. Continuing on. What powers muscles for the shortest period of time? So talking about the energetics of muscle contraction. So this one's a little tricky. Okay, so what does phosphocreatine do? Donates phosphate to form ATP, right? So the first thing you run out of when you're having muscle contractions is ATP. You have limited stores of ATP in the muscle, but that's directly used for energy production. After that, you have to have the phosphocreatine donate that phosphate in order to generate more ATP, right? After you run out of that, which takes about how long? It's just seconds, essentially. Yeah, so seconds on that order. And then going into glycogen, then you have maybe how much energy? Because when we're breaking down a lot of that glycogen into glucose, and then getting energy from that because we're forming acetyl-CoA and all that good stuff. And then that's good for how long? About a minute or so, and then you rely on oxidative phosphorylation for kind of the rest of the energy production. So technically, ATP is providing the shortest energy source, because your muscles always have a little bit of ATP being stored up, and then the phosphocreatine and the glycogen will take over from there once you deplete those stores. Okay, make sense? All right. But otherwise, people that chose the 43 of you that chose that, again, that's a very good thought process you have going there. But just think about what ultimately is doing it was a good thought process. That's why I put the ATP there, to try to make you guys think a little bit more kind of closely about that. Okay. Moving on. A skeletal nicotinic blocker would cause which of the following? It's not a nicotinic, it's a nicotinic. Should be something like an antagonist on the skeletal nicotinic receptors. Very good, very good. Right. So remember, here we're specifically talking about nicotinic receptors that are on the skeletal muscle, right? So that's going to be directly involved with that neuromuscular transmission. We're not really going to be focusing so much on the autonomic side of things for this component of it. So again, you can have specific subtypes of nicotinic receptors, which we didn't really get into, but there's specific ones for skeletal muscle that we can have drugs that will be specific for those rather than affecting basically all like the preganglionic fibers in the autonomic nervous system. Right, so paralysis would be the biggest thing here. This is where we have drugs like rocuronium or pancuronium, cisatracurium, right? They sit on that receptor and they cause paralysis, and then you can intubate the patient or you can perform surgery on them or whatever you need to do. One of the big things I'll always talk about whenever you give paralytics, what else should you give to the patient as well? You need to give sedatives, right? So you never want to have a patient paralyzed without sedatives on board, because imagine if you could not breathe on your own, move your muscles at all, you'd be pretty freaked out, right? So that's one of the things that we really harp on a lot, or at least I'll harp on a lot when we get to talking about that in pharm. So you always want to give sedatives first, and then you can give paralytics after. So a little bit of a tangent there. So again, really wouldn't, because of the specificity of these drugs, we really wouldn't have any effects on the autonomic nervous system. Yes, ma'am. Those are somatic muscles. You don't normally see paralysis of those muscles, right? You still have some, I've not at least seen that clinically, where you would have relaxation of those muscles. But if anything, you would think if you paralyze the external urethral sphincter, right? So if you paralyze those muscles, you'd have, if anything, urinary flow, right? You have incontinence. Yeah, I technically, because we don't like give paralytics to patients and then they don't just like urinate on themselves. Especially if they're going for surgery, a lot of times I'll have like catheters placed in where you can collect the urine directly from the bladder. But like if we're intubating someone, we normally don't have time to do that, and they don't necessarily become incontinent. So I guess those muscles still maintain some control, so which is probably a good thing for our patients, right? All right, moving on. An alpha-2 agonist should cause which of the following? So remember what alpha-2 receptors do. just tell how hard the hamster's running on the wheel based on how quiet it is. Should I hook up like EEGs to all you guys while you're doing these things? See. Interesting. All right. So let's look at, so what do alpha-2 agonists typically do? Like where do they function? So remember, those are those autoreceptors we talked about, right? And when you activate those autoreceptors, what happens? That's part of that negative feedback loop, right? So when you activate the alpha-2 receptor, that will shut down further release of what? Norepinephrine, right? So think about those those adrenergic neurons, those norepinephrine secreting neurons. They have those alpha-2 receptors. Once they have enough norepinephrine out there in the synapse, it'll feed back, activate those alpha-2 receptors, and it shuts down further release. Okay, so basically, if we were to give something that was an alpha-2 agonist, so the kind of prototypical one's called clonidine. I'm sure some of you guys have heard of that. It's an antihypertensive. Sometimes we'll use. Basically, you're shutting down from the CNS down that sympathetic outflow. So we call that sympatholytic because it's decreasing the amount of secretion of things like norepinephrine. So you would not expect to see tachycardia because you'd see less activity on what receptors? On beta 1, right? You would not expect to see hypertension because you have decreased activity at what receptors? You see decreased alpha 1 activity, right? Because there's less norepinephrine being released to activate those alpha 1. So you should see, if anything, hypotension, which is why we can use these kind of drugs as an antihypertensive. You shouldn't see sweating necessarily, because again, you wouldn't have any kind of activation, especially like the muscarinic receptors or anything. But why would you see meiosis? What do you think? It's the opposite of what we should normally see. So think about those radial muscles, right? So radial muscles respond to what? Right, alpha 1 activation, right? So those radial muscles, normally when they're activated by alpha 1, you see constriction, and that should cause mydriasis, right, as you pull the pupil apart, right? On the other hand, though, if I were to block that, if I were to inhibit that outflow of norepinephrine by activating alpha 2, you would see a relaxation of those radial muscles, and you see contraction of the muscle there, basically because it'd be kind of unopposed muscarinic effects at that point, right? Because there's always a balance between your sympathetic and your parasympathetic, right? That's why we have that tone, that concept of tone. So the muscarinic effects would kind of take over and see more of that meiosis. Clinically, that becomes important because if we have especially like overdoses, I usually relate things back to overdose because this is kind of where you see the biggest kind of physiologic effects from massive doses of drugs. But when you think about like an opioid overdose, something like hydrocodone or morphine, what do you think about the pupils? What do you like? That classic kind of thing. Normally see like pinpoint pupils. So when you hear about like an opioid overdose, you expect to see pinpoint pupils. And so this is one of those things where they come in, they're like really somnolent, and they're not really breathing that well, and they have pinpoint pupils. You're like, oh, that looks like an opioid. But what you end up seeing is that something like an alpha-2 agonist can actually mimic that because it causes meiosis, causes kind of relative hypotension, bradycardia. It looks very, very similar. So this provides kind of one of the challenges for us as toxicologists when we're trying to decide what type of ingestion was this person exposed to, because that changes your management pretty significantly, right? Whether I'm going to give one type of antidote versus another. So it just should give you an idea how that actually comes up in the clinical world. Does that make sense? That mechanism there? So think about things that will either block the receptors, think about things that will decrease the outflow of specific neurotransmitters. All those relationships are important to keep in mind, okay? If you have a good understanding of this stuff, you're going to be well ahead, especially for a lot of the drugs that affect the autonomic nervous system for farm.
Okay, so it's like activating alpha-2 block alpha-1.
Indirectly, right? Because I'm decreasing the amount of norepinephrine being released, which leads to less the substrate or the neurotransmitter to actually activate the receptors, right?
So then it kind of will mimic the muscarinic effect, is what you're saying?
Not necessarily muscarinic. You might have some of those muscarinic effects start to take over, right? So if they're kind of antagonistic to one another, which is why we see more of that meiosis that can occur there. Because at that point, you really just have those muscarinic effects causing contraction of those the circular muscle rather than having really any effect on the radial muscle. Mm-hmm. All right. Move on. These are the kind of questions that might pop up on an exam that might be like tomorrow. So have a good understanding of these relationships. That's good sound. Which of the following would occur after placing your left hand on a hot stove? Remember that reflux we talked about? I think I might have goofed this one up, actually. Hmm? I don't know. We'll see. What the answer is. I don't think I actually did. No, I think it's right.
Oh my god.
Didn't I ask what did the fox say? Anything like that. Okay, so what is the kind of the reflex? So if I put my hand on a hot stove, my left hand, what should happen? I should retract my left hand, and I should do what with my right arm? You typically extend out, right? So that's kind of that reflex. So think about like you stepped on a nail. Same thing would happen there, where you would take your foot away and you would kind of transfer weight over to your right leg. Same thing happens here. So looking at that, what should happen to the left bicep? Contract. Okay. What about the left tricep? Should relax. Okay, good. And then, which was one of the options. Okay, so I goofed up the answer. Like I said, I might have done that. What should happen with the right arm though? How about the right bicep? Relax, right? Because then the right tricep does what? Contracts. Okay, good. So I goofed that up. I very much apologize. But good job, 43 of you. Got that correct. No points, unfortunately, because I cannot go back and fix that. But just know in your mind that you were correct. Because isn't that what's really important? Yeah, so there's two correct answers there, right? So you should see the left tricep relaxing because you are contracting your left bicep in that case, right? Because you're trying to move your arm away from the painful stimulus while you're extending the opposite arm, the contralateral side. So I apologize for that. Again, Po Buddy's perfect. Okay, good job. Continuing on. Okay, so when contracting the bicep, which of the following events is also occurring? Oh boy. All right. So remember, what's responsible for contracting the muscle spindle, or the ends of the muscle spindle, I should say? What neurons? Those are gamma motor neurons, right? So those are actually controlling the muscle spindle. How about for the extrafusal fibers of the rest of the muscle? Those are the alpha motor neurons, right? So if you're actually looking at what's causing the contraction of the muscle itself, that's going to be the alpha motor neurons. It really does not innervate the muscle spindle at all. The gamma motor neurons are responsible for that. Why is it not the Golgi tendon organ? Yeah, is it specifically going to be located in the tendon? It's going to be detecting what? Yeah, increased tension, and that should cause a reflex of what if it were to detect that? Relaxation, yeah, because again, you don't want to rip your muscles off from the tendon, right? So you want to do that, or from the bone. How about the alpha motor neurons fire at a decreased rate? Yeah, that would end up relaxing the muscle. So this is actually would be an increased rate when this was occurring. So looking at this, why would the gamma motor neuron be trying to elongate the muscle spindle when you're having contraction of the bicep? Right, so we want to keep basically that length of the muscle spindle relatively the same, right? So as I'm contracting the bicep, as I'm shortening that muscle, what would also happen to that muscle spindle? It would shorten as well, just because just by the actual shortening, it would kind of crunch in that muscle spindle, and it would detect that, hey, we're having too much shortening here. We need to have a reflex that would cause the muscle to elongate. We don't want that to happen because we're willing our left bicep or our bicep to contract. So in that case, because you have the alpha motor neurons that are firing on the muscle, you would also have almost kind of in a 1-to-1 kind of ratio the gamma motor neurons firing at the same time. That would both cause the muscle itself to shorten, but that causes the muscle spindle to elongate and stay roughly about the same length regardless, right? So that way you can keep it at a good length, and it allows for those reflexes to remain intact. Make sense? Yes, ma'am.
You talked about how, because I remember reading that they occur simultaneously, the alpha and the gamma. So why doesn't the alpha motor neuron cause the muscle spindle to
Because they don't innervate the muscle spindle, right? It's just the gamma motor neurons that are innervating that.
Okay.
Yeah, the alpha motor neurons are just responsible for contracting the actual muscle itself.
On the receptor, correct?
Through the nicotinic receptors, yeah, it would spread that action potential and cause the whole pathway that we know about. Right?
Okay.
Yep.
Thank you.
Mm-hmm. All right.
Wait, so alpha makes the muscle contract, and gamma makes the spindles elongate.
Yeah, because they're contracting the ends of those muscle spindles, right? Because it's going to end up contracting on the ends there, and it kind of stretches it out.
Okay.
Yep. Perfect. Because again, remember that middle of the muscle spindle doesn't have any kind of contractile component. It doesn't have like the actin and the myosin, just the ends of it do. So that way you can relax or contract it. Okay. An acetylcholinesterase inhibitor would cause which of the following effects? All right. So, what happens if I were to give someone an acetylcholinesterase inhibitor? Acetylcholine levels go up, right? And so, does that only affect muscarinic receptors? It'll be non-specific, right? Acetylcholine doesn't matter it doesn't care what type of receptors it's hitting. It'll affect nicotinic and muscarinic, okay? So that's important to remember, as opposed to if I were just giving an anti-muscarinic drug or an anti-nicotinic drug, or a cholinergic, a muscarinic agonist or something like that. So keep those distinctions in mind. Notice this is a kind of non-specific kind of increase in the acetylcholine levels, okay? So based on that, do you remember the mnemonics we used to remember our cholinergic effects? Dumbbells. Yep, so we see our dumbbells. So we see, what's the D? Diarrhea, defecation, is a U. Urination, M. Meiosis, absolutely, B. Bradycardia, bronchorrhea, bronchospasm. Yeah, those are killer Bs, right? That's what's going to kill the patient. No one pees themselves to death usually. What's the E? Emesis, who should see vomiting. L. Lacrimation, S. Salivation, yeah. So basically, they're secreting from every organ. Every mucous membrane is going to be secreting fluids, essentially, right? Those are the muscarinic or nicotinic effects. Yeah, those are the muscarinic effects. You guys remember the nicotinic effects we talked about? The days of the week. So M would be, yeah, this would be mydriasis. And think about that being from the nicotinic stimulation of those preganglionic fibers, right? Because that can actually affect the sympathetic nervous system as well. T would be tachycardia. Be the W. Be weakness, yeah, because again, when you overstimulate the skeletal muscle, again, remember that fatigue that occurs over time. You see weakness, and then what's the H or the Thursday, Thursday? The hypertension. You should expect to see that. And then how about the F? Yeah, fasciculation. That goes back to that muscle activation. You see initial skeletal muscle activation followed by that weakness and then eventually paralysis, right? So based on that, we would not expect to see dry skin. You expect to see a lot of sweating. You see kind of copious secretions. You would not expect to see constipation. You expect to see diarrhea, if anything. And then hypotension really shouldn't see much of an effect here. Remember, going back, if anything, you would see hypertension briefly from the nicotinic effects. And then, if anything, you find the muscarinic effects kind of take over later on. But that's kind of really germane to our discussion. But the only thing that really would be guaranteed to happen specifically would be bradycardia from the muscarinic effects. Okay? Everyone with me? All right. A beta-1 agonist would cause which of the following? So a drug that does this called dobutamine. If you hear that one, that's specifically a beta-1 agonist. Yeah. Oh, I should have said it in the beginning. I would have known exactly what the answer was. All right, good job. Yeah, so tachycardia would be the biggest thing. So increased contractility, increased heart rate, namely due to the beta-1 agonist effects, right? Bronchodilation is mainly mediated by what? Beta-2, right? Beta-2 is going to be for smooth muscle relaxation. Beta-1 is primarily on the heart, causing increased contractility, heart rate. Okay. Should not see hypotension. If anything, you might see that a little bit with the beta-2 agonist. Again, with that smooth muscle effect. Should not necessarily see urination. If anything, sympathetic stimulation of the bladder and the urinary tract should do what? Yeah, should inhibit it if anything, right? So you're going to see relaxation of the detrusor muscle. Alpha effects on the internal urethral sphincter should be constricting that, preventing urination if anything. Okay. Again, usually with the detrusor muscle, more beta-2 effects again there because you're causing that smooth muscle relaxation. Okay. All right. Seems like a more somber game than usual. Okay. A norepinephrine reuptake blocker would cause which of the following? So we're blocking the reuptake of norepinephrine. Think about your cocaines. Think about your some amphetamines. Speaking of cocaine, what do Eric Clapton and coffee have in common? They both suck without cream. Classic rock joke. All right. Hmm? He used to be in a band called Cream. And people, it used to be really good. Huh? He was not in the Eagles. Don Henley was in the Eagles. Who else is in the Eagles? Joe. I just watched like a documentary on them like a few months ago. It was really good. Okay. Anyway, so what would you expect to see from a norepinephrine reuptake blocker? So this does what to norepinephrine levels in the synapse? Should increase them, right? So it should be seeing increased sympathetic outflow. So you expect to see hypertension due to what effects? Which receptor? Well, which subtype of the adrenergic receptors? Alpha, yes. Alpha effects are going to be called alpha-1 specifically are causing hypertension to occur. Wouldn't necessarily see dry skin if anything. Usually they get very hyperthermic when you see that, so typically they sweat if anything. Would you expect to see bradycardia? No, you expect to see beta-1 effects due to the increased norepinephrine. You expect to see tachycardia, absolutely. And then meiosis not occur. Usually you see people who are like on amphetamines or cocaine, they get very midriatic pupils, look like big saucers, big black saucers in their eyes from those norepinephrine effects. So, and again, like when you see patients, like, you can look at them. And so for instance, if I have a patient that says, they overdose on cocaine and they come in and they're sleeping quietly, and their pupils are myosed and all that, I'm just like, well, that doesn't look like cocaine, right? Like you have to look at the patient and see like, well, does this make sense based on what the history is? And a lot of times that'll lead you down either certain diagnostic routes or certain antidotal routes or different things like that. So it's important to understand what these kind of effects you'd expect to see and see where the consistencies or inconsistencies are, right? Okay. When a neuron develops an action potential after it has been excited by multiple neurons, this is considered what type of effect here? I didn't have enough characters in the question. So you consider that to be spatial summation, temporal summation, TREP, or a fused tetanus. When you have multiple neurons coming in and helping one single neuron fire. All right. Yeah, so that would be considered spatial summation, right? So you have lots of different neurons that are feeding into one neuron. All of them can be excitatory. You may see some being inhibitory, but you should have enough excitation to cause an action potential to occur. So remember that graph where you saw that, like, 4 incoming excitatory signals would maybe not have been enough to achieve that threshold for an action potential. 8 wouldn't really do it either, but 16 neurons was enough to do that. That was an example of spatial summation. What would be temporal summation? Yeah, that one neuron that's feeding into another one that's that would be firing frequently enough to increase the resting membrane potential to get to that get to the action potential threshold, right? So it'd be temporal summation. What's fused tetanus? Yeah, so basically you have such enough of a stimulatory effect on, say, the skeletal muscle, you would see basically consistent contraction because the action potentials are coming fast enough to not really give it a chance to relax at all, right? So you see basically one force of contraction would stays pretty consistent. And then what is this trap effect? A trap? Yeah, so it's kind of like a stepwise increase in that force of contraction based on multiple action potentials affecting the muscle. So you see basically that stepwise approach, the kind of trap effect, and then eventually you're going to get to that fused tetanus state, right? So basically kind of one precedes the other in this case. But yeah, so spatial summation would be the example here. All right. What is the function of the T tubule? Yes, ma'am. Yes, multiple fibers feeding into one. The temporal summation would be multiple incoming excitatory signals from just one neuron, right? So firing quickly enough where you have an increase in that resting membrane potential to a threshold level, and then you have an action potential.
So then you talk about multiple fibers and frequency summation, but I didn't remember you saying those words. So I was just making sure they were they correlate.
Yeah, yeah, essentially, right? Yes, that frequency is kind of very similar to the temporal summation. Yep. Okay. All right. So function of the T tubule, they allow propagation of the action potential, right? Because the T tubules go where? Yeah, basically through the muscle, right? So you can have an action potential because normally the neurons are going to be kind of firing just on the surface level of the muscle, but you need to have action potentials hit all those myofibrils even deep down in the the darkest depths of the muscle. So this allows for that to occur because of that T tubule. What allows for so why does it not allow calcium into the myocyte? What does that? Yeah, so it's coming out of the sarcoplasmic reticulum. Remember that ryanodine channel that's going to allow calcium to flow out. Now, where is calcium inflow to the muscle really important for contraction? What type of muscle? Yeah, smooth muscle is going to be much more important for that, right? So keep that in mind. Don't produce elastin or that titin protein, and they do not help with the cross bridges there, right? The T tubules just allow for propagation of that action potential down to the depths of the muscle to allow for kind of synchronous contraction there. Okay. Fantastic. All right. Which area of the cortex would be involved with planning out steps to perform a math problem? Which area? All right, good job. So, prefrontal association area. Remember we talked about those lobotomy patients, like when you kind of severed that connection between the frontal cortex to other areas of the brain, you saw that those patients would be pretty placid for the most part, but you also saw that they couldn't really think out multiple steps to solve a problem, right? They didn't think about what their actions would cause as kind of secondary effects there. So that's why they would be very inappropriate, like in social settings, maybe like sexually inappropriate with people, because they just could not plan out multiple steps and things like, wait a second, what would happen if I were to do this, right? They don't have that working memory there. What does the secondary somatosensory area help us to do? So it gets a lot of input from the primary somatosensory cortex, but what does that do for us? Yeah, you process a lot of the inputs, right? So you can process things like, the shapes and colors that you're seeing, and kind of trying to input those into some kind of usable information. How about this parieto-occipito-temporal association area? Yeah, word recognition, either read or heard, things like that. So a lot of that is going to be fed up into that Wernicke's area, and that kind of helps with, that language processing of and then where the intellect kind of comes from. And then how about that limbic association area? More like mood, some memories, or hippocampus, things like that. All right. And again, when you saw some of those patients who were like, particularly they got the lobotomies, they also saw that they became very calm, and that a lot of that had to do with some of the cutting of that limbic association area as well. So that's kind of a side effect of doing that. Okay. Which area of the brain functions in coordinating muscle movements to produce speech? Let's see. Good. Yes, that is Broca's area, right? So basically what you see is that you have information that will come into the auditory or the visual areas of the cortex. That gets fed into which area? Wernicke's area, right? That's where a lot of the language processing actually happens there. And then that will feed, when you decide you want to say something, it'll feed into where? Broca's area, right? That's where a lot of the speech, the actual coordination of, that's why you had those patients that had damage to Wernicke's area. They couldn't figure out what they wanted to say, right? They would just kind of talk. They could talk fine. Their Broca's area was okay, so they could say words, but none of it made sense. Versus a person who had damage to the Broca's area, they had a very hard time developing those words. The thoughts were there, but they just could not communicate them very well, right? So Broca's area is really, really important for that. Okay, the angular gyrus is important for transmitting kind of the information from the visual areas of cortex and the occipital lobe up to Wernicke's area. So if you have damage there, that's where you can see things like that dyslexia that can occur. Okay. Catecholamine O-methyltransferase metabolizes which neurotransmitter? All right. Yes. Dopamine is the correct answer here, right? So remember, it's catecholamine O-methyltransferase, or COMT. What was the other enzyme? MAO, monoamine oxidase, is also really important for metabolizing things like dopamine. What else does it metabolize? Yeah, norepi is going to be another big one. Epinephrine to some degree as well. And then what else? Monoamine oxidase can also metabolize which other one? Serotonin, yeah, that's the other big thing. So COMT is going to be more relegated just to like dopamine, epinephrine, norepinephrine. Because remember, those are all your catecholamines. They're all kind of have a common pathway for their formation. If you go back and look, you see the dopamine feeds into form norepinephrine, then norepinephrine feeds into forming epinephrine. So they all have very structural, have a lot of structural similarities. So a lot of these enzymes can work on multiple neurotransmitters. Key point here. So why do we care that COMT inhibit or that will metabolize dopamine? Like, why would that be important for us? So, I mean, is there any disease states we talked about where you have decreased amount of dopamine being released? Parkinson's, absolutely. So this is a good drug target for treating patients with Parkinson's. You know, when you have someone with Parkinson's, it's a gradual decline. It's not like all of a sudden their dopamine neurons are dead, immediately. But certainly you see a gradual decline as they start to have destruction of the dopaminergic neurons. So one of the things we can actually do is we can give a COMT inhibitor, and that will help to prolong the half-life of dopamine, allow it to stick around for longer, so that you can have improvement in their symptoms. Right. Sometimes we'll also give like a monoamine oxidase inhibitor as well. So we'll look at drug therapy for those when we get to that section in Pharm, but just keep in mind these drug targets can be utilized to alter levels of these different neurotransmitters to try and help treat some of these disease states. Okay, what metabolizes acetylcholine? Acetylcholinesterase, absolutely. How about glutamate? Glutamic acid decarboxylase, yep. And how about GABA? GABA-train, yeah. So a lot of those are pretty easy to figure out because the name's right there in the enzyme. So that would be pretty useful. This one's a little bit less intuitive. Perfect. All right. Which portion of the cerebellum is involved with movements of the hands and feet? Make sure I found a picture that didn't give away the answer. All right. So remember, go back and show the image. So what did kind of the vermis here control? Yeah, basically the axial skeleton, right? So for things like posture, movement of the neck, the head, shoulders, things like that. Versus here in the intermediate area, this is going to be the hands and the feet, right? See a lot more coordination and movement there. And then how about this lateral zone? What does this do? Yeah, it helps with coordination of movements, planning of things, not necessarily planning, but the sequencing of movements is going to be occurring here more in the lateral areas. Good. Fantastic. Moving on. Which type of brain waves are you likely having right now? You're thinking really hard, you're focusing on the question. Which one should we be seeing? I may see a few inappropriate waves around here, but I think mostly I expect to see this one type of wave.
This could be multiple right answers.
This has one right answer. Oh, my joke questions have come up yet. I'm kind
I
of.
had my eyes closed when I read the questions. So.
Oh, is that true? Yeah, you had to read the question somehow. Do you have transparent eyelids?
Just focusing.
Yeah. Okay. I can read via sonar. Yes. Okay. So when do you have alpha waves? You're not really thinking about something. You're just kind of sitting there, just kind of quietly, just not really contemplating anything. Those would be more of the alpha waves, right? So typically those are higher in voltage than your beta waves. And why is that? Because you're focused on something. So in those beta waves, imagine like a lot of the extra neuronal circuits are firing. A lot of times they cancel each other out. So we don't really see as much kind of grouping up of those action potentials. And so you don't really see as high of a voltage there. Because a lot of things, some are inhibitory, some are excitatory. They cancel one another out, essentially, right? So we see a lower voltage. Alpha will be a little bit higher voltage, a little bit slower frequency. Because again, you're having not necessarily as much concentrated effort towards thinking about something. How about theta waves? When do those pop up? Emotional stress. What else could occur? As you're starting to go to sleep, you start to develop some theta waves, and then how about like in REM sleep? What do you mostly have? REM sleep, you see a lot of beta waves, right? Because that's when you're actively dreaming, right? You see a lot of activity going on there. Versus you'll see a kind of there's some vacillation there, but in the deepest stages of sleep, what do you see? That's where you see the delta waves, right? So the delta waves are very slow. They have very high voltage because, again, a lot of those active potentials, you can see that summation there because a lot of them are just kind of firing all together at the same time. But when you start to have like REM sleep and you're dreaming, like you have a lot of beta waves because your brain's kind of actively, it's, metabolism increases. You're thinking about things. You're performing these kind of visual imageries, all these different things. Okay, does that make sense? So hopefully you guys are thinking about the question. You thought, okay, this must be my beta waves going right now. Okay. Hopefully no one's exhibiting any delta waves. It's kind of dark in here though, so it might be the case. Okay. Does that make sense? Kind of a goofy question, but I think it illustrates the point, hopefully. So during the test, you guys will be having lots of beta waves, I hope, right? Okay, which of the following is false regarding synaptic transmission? Which one is false? Gotta read the questions. I try not to put this on the test, but I like to keep you guys on your toes during the review. All right. So yes, this is true. Activating voltage-gated calcium channels oftentimes is going to be releasing neurotransmitters, right? So you see opening up those channels, the calcium flow is in, causes exocytosis of those vesicles, right? Autoreceptor activation decreases neurotransmitter release. Absolutely. This is what we talked about as alpha-2 receptors. The neurotransmitters feedback, cause a negative feedback loop, and lead to less neurotransmitter release. Neurotransmitters can be metabolized or taken back up by the neuron. Absolutely. This is really important because a lot of times the CNS does not want to double work. If it can recycle, it will do so, in which case you have those reuptake transporters like serotonin, dopamine, norepinephrine, all those have reuptake transporters, but also some of those those neurotransmitters will be metabolized as well, right? So it's just both will occur. And we say communication is often two-way. Not the case. This is often one-way transmission there, right? Okay. Fantastic. What's the psychoactive component of these magic mushrooms? This is for no points, but because we talked about mushrooms, I figure this is good. You have a question? Okay, just relaxing. This kind of mushrooms grow on you after a while. Interesting. Yeah, so psilocybin is actually the component of those magic mushrooms. So we talked about the Amanita muscaria. That's where that's the kind of the Mario-looking mushroom with like the red and white caps there. That contains muscarine. Can still be used for some psychoactive, hallucinations and things like that. That's why you see it used for certain, spiritual or just they can use it for like spiritual events and things like that. So you see, they also call that fly agaric is another name for that mushroom. So you see that used in history. Certainly not nicotine. That typically comes from tobacco plant, right? And how about lysergic acid diethylamide or LSD? Where does that come from? Yeah, absolutely. So it comes from a lab, but you'll find it actually has some similar characteristics to some of these kind of natural substances. So LSD is probably like, if you were to crank the hallucinogenic kind of scale up to like 10, that would be LSD versus like psilocybin, maybe like a 2 or a 3, right? Depending on your dose. But that would be the active component there. So if you ever hear someone doing magic mushrooms, that's what they're using it for, right? Okay. Again, don't do drugs. They're bad for you. Okay, slowly lowering a barbell after a bicep curl is considered which type of contraction? So I have a little GIF here. So the downward phase here. It's isotonic, it's isometric. This guy's very serious about his bicep curls, as you can tell. He's probably in the squat rack doing it. Perfect. All right. So, right. So again, when we say isotonic, what does that mean? Yeah, the length is changing, even though the basically the tension is staying the same throughout, right? Versus isometric would be what? Yeah, no change in length. The tension is it can change it, right? Perfect. All right, and then so we were saying the eccentric phase is going to be what? Yeah, the lengthening of the muscle, right? So you're not necessarily like relaxing the muscle because you just drop the barbell, but if you're slowly lowering it down, that would be considered the eccentric phase of contraction, and then you'd have the concentric would be the upward motion or the shortening of the muscle during that phase, right? Okay. The greatest is now the greatest. Good job. Come on. Okay, which of the following can cause seizures? This may or may not be a trick question. They're all correct. There's 4 right answers. What was the point? Actually, I think I did get points for that one, so hopefully you answer quickly. So what is the point of this question? A lot of things can cause seizures, right? So when you have a patient who presents for, especially with no history of seizures, and they present for new onset seizures, you need to widen your differential because there's lots of things that can be involved with this, right? And so you have to be very judicious in your use of labs and different things, getting a good history where you can from either people around the patient or their family in order to rule in things in order to try to get a good idea of what could be causing the seizure to occur, right? Certainly hypoglycemia, first thing you check. When you have a patient comes in with a seizure, check a glucose, right? Because that can be a very easy thing to fix, right? I can give dextrose very easily through an IV and fix that problem. Electrolyte disorders, hyponatremia can be a really big thing, especially if someone, especially during the summertime, they go out to one of these boot camps, they're losing a ton of salt through the sweat, and they just drink a ton of water. Hyponatremic seizures can be very common in that kind of case. Stroke can do this, absolutely. And then toxins. We have a whole huge mnemonic for different toxins that can cause seizures. I won't get into it here, but Otis Campbell is the mnemonic we use, just to give you an idea how the length of different toxins that can cause that, right? So, yeah.
Can't you put them like on a low carb diet though and have hypoglycemia in order to have the acidosis?
You may acutely have a drop in their blood sugar, but you don't necessarily, because again, if they don't have carbohydrates around, what do they rely on for energy? Fats and proteins, right? So they will eventually hit a baseline where they are still maintaining their blood glucose, right? Because they're using alternative sources of energy, but they become more acidotic because of a buildup of things like acetoacetate and other type of acids. So because they get slightly acidotic, that does what to the neurons as far as their excitability? Yeah, they're hyperpolarized, if anything, so they end up becoming much more difficult or a little bit more difficult to fire. So that's why we'll do ketogenic diets for some of those seizure patients, right? And so it can be very difficult when you have a ketogenic diet patient comes into like the hospital because we have to make sure that all the meds we're giving them have no sugar in it. And again, when you're dealing with kids, a lot of times the drugs come in what formulation? Tablets, liquids. A lot of liquids, right? And a lot of those liquids and suspensions and things all contain sugar. So we have to convert them over to using tablets that we crush and put in water, all kinds of different things. So there's lots that goes into it. You just make sure their diet orders are set correctly. All those kind of things go into it. So it can be very complicated, which is why we kind of hold it off until they have failed many other types of therapy. All right. Which part of the brain is especially important in the formation of memories? Like the fond memories you'll have of physiology. least if you learn nothing else today, you'll know what magic mushrooms contain. All right, that is correct. The hippocampus is very important here. Remember, we saw if you have hippocampal damage or lesions there, you have the inability to make new memories, which we call what? Anterograde amnesia, right? They can't generate new, they can't convert those kind of short-term memories into long-term. So, yeah, so hippocampus is very, very important for that. Hypothalamus does what for us? Yeah, a lot of endocrine regulation, lots of different things kind of helping control kind of most of the limbic system. How about the amygdala? Emotions, yeah, and cerebellum, we already mentioned. Yeah, helping coordination of movements, sequencing of movements, things like that. Good. All right. Which of the following is a way that smooth muscle contraction differs from skeletal muscle? And of course, I forgot to turn off my steam, so. Just cut that off. Never know when my cousins will be online and be like, hey, jerk face. Fortunately, they don't wake up this early, so. Yes?
Just a question for the last one. So, I get it's the hippocampus, but the amygdala is involved with the limbic system. So could you say something lower memory because of reward and punishment center?
You probably would see a little bit of help there, but we're really just kind of focused on what like kind of the primary thing. But yeah, certainly reward centers, punishment centers are all super important. Yep. Yeah. Okay, so let's look at this. So calcium is not needed in smooth muscle contraction. False. It is very important for smooth muscle contraction because, again, we don't really have the sodium channels opening up to spread an action potential, but you will have voltage-gated calcium channels that will open up in response to action potentials that will allow calcium to flow in, and that triggers off the contraction, right? Sarcoplasmic reticulum is more developed in smooth muscle. That is false. It is less well developed because, again, think about skeletal muscle. All the calcium is coming from where? Sarcoplasmic reticulum has to be very well developed in the skeletal muscle. In smooth muscle, on the other hand, most of it's coming from where? Extracellular space. Yeah, a little bit's going to come from the sarcoplasmic reticulum. Majority of it is going to be coming from the extracellular space. Okay, important thing to remember there. Troponin is only found in smooth muscle. Yeah, only found in skeletal muscle, right? Troponin is responsible for doing what? Binds to calcium, right? And that helps to do what at that point? Uncover the active sites for that binding from myosin to actin, right? So that's troponin is going to be more found in skeletal muscle. Then myosin must be phosphorylated in smooth muscle to contract. This is true. Remember, looking at how the steps there. So you have calcium entering into the smooth muscle cell. What happens at that point? Binds to calmodulin. Binds to calmodulin. That activates that protein. And then what happens at that point? That myosin light chain kinase, remember that phosphorylates the myosin, which will trigger it to be activated so you can start to have that contraction occur, right? Those cross bridges can start to form once you have phosphorylation of the myosin heads, okay? You guys remember what will come along and get rid of those phosphate groups? Yeah, myosin phosphatase, right? It's right there in the name. It dephosphates myosin, essentially, and that will lead to inactivation of those myosin heads, okay? All right, so that would be the big difference here. Yes?
How is this different from skeletal muscle?
So because you don't have to have phosphorylation of the myosin heads in order to have contraction occur, right? So remember when for the myosin heads in skeletal muscle, you have ATP that will bind to it, ATPase will cleave it, and then you have the phosphate in the ADP, right? That will lead it to be in that kind of Cox position where it's ready to fire. But you don't have to have phosphorylation necessarily of that myosin head. There's a phosphate group there, but it's not really the same process as you would see in the smooth muscle.
Okay.
Yep. All right. When would the force of muscle contraction be weakest? Okay, so keep in mind, when do we see that we had the strongest force of contraction? All the myosins overlapped with actin. You start to see a decrease in contraction, though, if you were to shorten the sarcomere even further, to where you see the Z disc start to kind of crumple in the ends of the myosin. You saw a decrease in contraction force, right? Remember that graph? On the other hand, though, if you were to have, say, no overlap whatsoever, how much contraction can you, or how much tension can you make in the muscle? 0, right? So you have to have some kind of overlap there happening. Otherwise, cross bridges are not going to be able to cause that kind of ratcheting formation to move the actin closer to those M lines, right? That H zone is going to be will never shorten at that point. Okay. All right. Which of the following is false regarding neurotransmitter synthesis? So which one precedes formation of the following? All right, so this is incorrect. What would be the correct? Yeah, you reverse it, right? So glutamate precedes formation of GABA. You may be like, well, why does that matter? Who cares, right? That does become important for especially, at least from the pharmacy standpoint, for certain drug interactions. So for instance, if I have a patient who is taking a drug for tuberculosis called isoniazid, basically inhibits the ability for GABA to get, or glutamate to get converted over to GABA. So if you inhibit that, what do you think could also occur because of that? Seizure, yeah. So you end up having a buildup of glutamate, but you have too little GABA, so you end up seeing seizures. That can be a very important side effect, in which case we have to give a supplement along with that. You guys remember the vitamin that is utilized in formation of changing glutamate over to GABA? Yeah, B6 is really important there. So we give B6 to those patients taking isoniazid to prevent those problems from coming up, because it inhibits that paradoxal phosphatase, or whatever happened, whichever enzyme it was, but it involves pyridoxine or B6. Dopamine does get converted over to norepinephrine. It certainly does happen. Norepinephrine precedes conversion over to epinephrine, which is why you probably see some release of both norepinephrine and epi from the adrenal gland. You know, probably 80% epi, 20% norepinephrine, but there's still some there. And then tryptophan, we already mentioned, gets converted over to serotonin eventually. Okay. What is the function of the microglia? All right, yes, they are basically the macrophages for the CNS, right? So they will help get rid of foreign invaders, bacteria, waste products, things like that, and getting rid of them. What does the myelin sheath? Oligodendrocytes, and also what else in the peripheral nervous system? Schwann cells, absolutely. What forms the blood-brain barrier? Astrocytes, good. How about secreting CSF? Ependymal cells, yep, perfect. Fantastic. All right, I think 2 questions left. What's the name of this character? No points for this one. Who could this be? Better hurry. The correct answer is Link. His name is not Zelda. It is the Legend of Zelda, but Zelda is the princess. I must inform you. Who's Ganon?
bad guy.
He's the bad guy. That's who Link is fighting, and it's certainly not Mario. Whoever answered Mario, shame, shame, shame. That or you didn't have video games growing up. Okay, moving on. Last question, I believe. What is the function of ATPase in muscle contraction? Yes, it causes the myosin to assume the cocked position where it's ready to bind again to actin, right? So think about it, when you have, say, the cross bridge is already formed, when you lose that ADP and the phosphate off of that, the myosin head, you cause dissociation of the link between the actin and the myosin. ATP can then bind to the myosin, and then you will find ATPase will cleave that into ADP and phosphate again, which will cause it to take that original conformation ready to again bind to the actin, right? Right. So any questions on that? So again, keep your steps straight for what's going on during those phases of contraction. Will keep you good. Okay. All right, that is the end. Who's the greatest? Fantastic, good job. You apparently are the greatest. Karina, good job, fantastic. And Mr. Peanut Butter. Very nice job, very nice job. Yes, what is your question?
It says on the chart that a new molecule of ATP attaches to the myosin head, causing the cross bridge to attach.
Yeah, it's kind of it's hard to say because depending on which kind of figure you look at, you'll see that either the ADP and the phosphate coming off causes that dissociation. Some of it, the things like the ATP is actually binding, causes dissociation. Really, that's not super important for our purposes. It's just to know that once you have that dissociation occur, you have to have the ATPase will cleave the ATP, and that causes it to kind of get back in that original position. That's the primary thing. Because if you look at different charts, you'll find that they're ambiguous about that. And again, a lot of this is still somewhat theory in some cases.
And are we calling the cross bridge like the actual myosin head or the connection between the myosin head?
The cross bridge is when the actin and the myosin head are attached to one another. Yeah. Any other questions? Okay, I'll be here for most of the day if you have any questions, and then I'll try to be answering emails through the night if you have any questions. Otherwise, I will see you guys later.